Good morning, everyone. Again, welcome. I'm Margaret Brandt, Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. Thank you for joining what is our 10th Investment and Payment Workgroup meeting. We've almost been out this for a year, so very exciting to have all of your feedback along the way. So getting into today's agenda, we are kind of focusing on our two key areas, alternative payment models and primary care investment. So we will review the revised alternative payment model standards and goal recommendations, and then we'll also share with you a more updated primary care measurement approach and benchmark recommendations. And of course, as we always do, as a reminder, please introduce yourself in the chat. And if we welcome all of your questions and comments in the chat, and we use those during the meeting. And if we can't get to them, we review them and try to address them or consider them after the meeting. And I wanted to go over our timeline, and I can speak a little bit also to Beth's question about the board's role in the alternative payment model standards and goal adoption, and then also the primary care investment benchmarks. So today we are sharing with you updated versions of both of those items. We also will be sharing these proposals with the board next week in our next week's OHCA board meeting. And then we will come back to the work group, come back to the advisory committee for both of these items. And then for alternative payment models, are aiming to have board adoption of the alternative payment model standards and the alternative payment model goals by June of this year. And then, to be specific, the board does approve or adopt the alternative payment model standards and approves or adopts the alternative payment model goals. And then for primary care, about a month delayed from alternative payment model. So we are planning to come back to the board and the work group in June, and then present our final recommendation in July for primary care. And the board also approves or adopts the primary care investment benchmark. So I hope that helps address the question related to the board's role and outlines our timeline. And we are kind of, have several statutory deadlines that we're working towards. So recognize that some of this work is moving quite quickly, and we're iterating quickly month over month. So for this next, I'll get into our first agenda item. And here we wanted to present to you all revised alternative payment model standards and goal recommendations based on all of the feedback that we've heard from you all over the past few months, and then also that we heard from the advisory committee. So let's see. So just a quick reminder, sharing on the screen are alternative payment model standards. So these are, our 10 alternative payment model standards. We presented these to the board in February. We also released these for public comment along with the implementation guidance that we developed and the alternative payment model adoption goals. So just a note that these are our 10 standards, and all the details in terms of the standards and the implementation guidance are in the links available on the OHCA website. So I won't read in detail each of our standards, just a refresher that these are our 10 standards. So getting into the public comment themes that we received related to the alternative payment model standards. So this slide summarizes the kind of key themes that we heard across the feedback we received. So there was, overarching support for the standards and a few suggestions for specific language changes, and we've aimed to adopt as many of those as we think are feasible and relevant. One of the recommendations we heard was to emphasize that physicians should be part of the design and implementation and evaluation of APMs, to recommend more explicitly the need to increase primary care resources and reduce administrative burden, recommend naming the types of clinical staff or staff that can be part of a primary care team, and with the resources needed to address social, mental, and behavioral health needs, such as PharmDs and RNs. And then finally, we had a recommendation to encourage OHCA to include a new standard that provides access to clinical data registries and support teams treating patients with chronic conditions. So we have aimed to adopt many of these recommendations. So I'll walk through these fairly quickly, just some minor language changes that we are recommending in the implementation guidance. So this first one is for in implementation guidance 1.3, we've added a kind of a note that designing alternate payment models should include input from providers. And then on this next slide, here is where we integrated a note or references to the types of team members that could be included in primary care teams to provide the resources or the services needed to address social, mental, and behavioral health needs and reduce administrative burden or support teams in kind of working to the top of their license or being the most efficient. So we've included references to nurses, doctors of pharmacies, and community health workers as examples of interdisciplinary team members. And then our next proposed change is related to the implementation guidance for Standard 9 and 9.1. So the standards related to using accurate, actionable data. So we thought it was best to incorporate the clinical registry information into Standard 9.1 to emphasize the importance of that. So these are all of the changes we've made, just some kind of adjustments and additions to the implementation guidance for several standards to emphasize the importance of these initiatives or kind of these types of activities. And then also, if we didn't specifically kind of address any of the feedback, we think that most the standards and the implementation guidance really cover some of the feedback we received. So since we have a lot to cover today, I'm going to move into all our alternative payment model adoption goals and share the feedback we've received from the advisory committee, from the board, and also from our last meeting in March in the work group. And then we'll pause and open up for questions. So as a reminder, these were the goals, the kind of revised or an interim sharing of revised alternative payment model goals from our last work group meeting in March. So this revision was based on the feedback we heard from the OHCA board members that we needed to move a little quicker. They suggested shortening the timeline, varying the goals across different payer and product types. And we also heard kind of a need or emphasis on trying to kind of find a pathway for commercial PPO adoption to move quicker. So this is just a refresher of the goals that we discussed in March. And following that March meeting, we heard a lot of different feedback from various work group members and others. So we've are proposing today another revision to the alternative payment model goals. So this slide summarizes the feedback we received on the goals that previous slide and what we presented in March. So we did hear some feedback, especially from payers, of the challenge of using all members as the denominator for the alternative payment model goal in commercial PPO products. And so they emphasized that the feasibility of achieving a commercial PPO goal really depends on the decision regarding the denominator and how the denominator is assessed for PPOs. And then also in addition for commercial PPOs, in terms of the 40% goal we proposed, we heard kind of a mix of feedback that 40% may be too high in 5 years. There's support for the higher goal, and alternatively, there's support for the longer timeline of 10 years. And then also concern about self-funded plans being able to meet the goal. And then we also heard, going back to our prior proposal that we shared in February, that 75% was not realistic and payers would be unlikely to meet that goal either. And that was a 75% 10-year goal. And then in terms of the 5-year commercial HMO and Medicare Advantage APM adoption goals of 95%, we again heard like a little bit of mix of feedback, but that potentially the goal was too high over 5 years, that 90% may be more realistic. Some expressed willing to support the goals if payers believed the benchmarks or the goals to be feasible. And we also heard some feedback that goals should try to align across product types. So, and then just to summarize, when we presented these, the goals we shared in February to the board, these are some of the key themes we heard in public comment. Again, they kind of overlap with the goal or the feedback we heard in March. So there's one concern that the 10-year 75% goal is overly ambitious and maybe unattainable for commercial PPO or Medi-Cal lines of business. We also heard concerns that the goals and the timeframe may oversimplify the significant shift in the 10-year healthcare delivery system, the significant shift in healthcare delivery system that's required to meet those 10-year goals. We also heard that for the purposes of APM adoption and Medi-Cal, that the goal should be based on the denominator that includes only those non-dual eligible Medi-Cal members. And then additionally, we heard feedback about making sure the denominator is clear, as I mentioned on the previous slide. And then also requesting clarification on data reporting for self-funded plans, and that self-funded plans, if submitted, would be counted separately than fully insured population. So based on all of these kind of variety of inputs and feedback that we've received, we are sharing revised goals today. And then also wanted to walk through on this next slide some of the challenges as we understand them with attribution in commercial PPOs. So this slide presents kind of in this funnel a common approach to attribution in commercial PPOs. So it has, this is a visual representation of attribution and the types of accountable care arrangements or alternative payment model arrangements that are most commonly used in commercial PPO payment models. And, we just wanted to walk through this as context for why it might be challenging for commercial PPO plans to meet higher goals, but also wanted to emphasize that OHCA is continuing to recommend that all members be included in the alternative payment model denominator for commercial PPO alternative payment model goals. This is aligns with all our alternative payment model standards that are really focused on preventive care and population health management, and really want to emphasize engaging those members who may be less likely to receive care. So I'm sure many of you are probably kind of familiar with how this works, but just to kind of briefly walk through it, that in some, commercial PPO alternative payment model arrangements, that attribution only applies to members who access care, and then potentially only certain types of care, such as care through a primary care provider. And so not all members are always attributed to an alternative payment model arrangement. and therefore, and also if providers and members are not attributed to alternative payment model arrangement, this kind of narrows the member, whether the member is included in the goal, and kind of narrows the funnel to only members who receive a specific type of care, potentially by a specific type of provider. So again, just wanted to share this as context from our understanding about why it may be more challenging for commercial PPO plans to achieve the same percentage of members attributed to APMs as other payer types. And then also just wanted to share, especially and some like kind of lessons learned or just information we've learned about progress in other states, kind of what we've heard over our all of our feedback so far is kind of mixed feedback about how do we balance really pushing the industry towards alternative payment model adoption while also making sure that we're making change more quickly, knowing that we need to change. So, we need to move towards alternative payment model adoption to promote higher value, more affordable care. And we want folks to start moving. We also want to avoid, moving too quickly because we want to recognize that care delivery design and contracting takes time. And we don't want any of our goals to be ignored, especially considering that these are voluntary or non-enforceable goals. And we also want to make sure that small practices and we include broad participation in meaningful alternative payment model arrangements. So given this kind of balance that we're trying to achieve, we also looked at what was happening in other states with alternative payment model adoption goals. So just as an example, in Oregon, in the last year or so, the payer submitted data shows a drop of spending in Category 3 and Category 4 arrangements. So those HCP land, shared savings, and population-based payments in the commercial market from 2020 to 2021. And we're looking to learn more about why this might be from the Oregon folks. And then in Delaware, we have, from their experience, they had a requirement to move towards advanced alternative payment models, and that resulted in shifting of large health systems to advanced alternative payment models, but progress for other provider groups is delayed. So those are just kind of some of the contexts that inform our proposal today, along with all of the feedback that we've heard so far. So with all of that, these are our proposed revised alternative payment model adoption goals. And note that we are still continuing to seek feedback, especially from sibling departments on these goals. And these will be shared with the board next week. So the kind of key changes we want to emphasize here is that we are proposing to revise to a set of 2-year goals leading to a 10-year kind of end goal. So I want to emphasize that there will be 2-year goals. We will report on those 2-year goals and track progress against those 2-year goals. So our end goals here proposing by 2034 are 95% of APM adoption using Category 3 and Category 4 payments for commercial HMO and for Medicare Advantage. For commercial PPO, proposing a 60% adoption goal by 2034 as the end goal. And then for Medi-Cal, proposing a 75% alternative payment model adoption goal. So aim to kind of balance all of the feedback that we've heard, emphasize, recognize that organizations or different payer types are in different starting points. Also want to continue to emphasize the link to quality that's required in order for alternative payment model arrangements to count towards these goals. And then really reinforce that public reporting and progress towards the biannual goal, so those 2-year goals. And also wanted to note that we, since OHCA does not have alternative payment model adoption goal or alternative payment model adoption data yet. We've relied on the kind of experience from IHA in terms of their data and other data that we have available, that we may consider revisions to these goals after the first 2 years of data collection. So essentially kind of after those first 2 years, once we have a baseline established and we're able to understand progress towards that first 2026 goal, that we would then revisit these goals and adjust them if warranted. So wanted to emphasize that we're open to revisiting these goals after we collect some initial years of data. So, and quickly just wanted to share kind of some opportunities for accountability alongside the APM goals. So of course, there's transparency in our public reporting. As we've talked about previously, there's the potential for aligning contracts to focus on the APM standards and goals. And then OHCA also has opportunities to include progress towards APM adoption goals and standards in performance improvement plans. And these are the performance improvement plans that would be applied if a healthcare entity is not meeting a spending growth target. And also just wanted to share another example of, or share an example of what reporting might look like. So this is an example from Oregon of how they are reporting APM adoption by payer and showing, the APM adoption in category 3 of those shared savings arrangements, and then category 4 of those population-based payments. And then additionally, also wanted to share some examples of questions that we could explore through reporting. So of course, we have the percent of members attributed to APMs, which is the basis for our adoption goal. We can also look at tracking and reporting on, percent of dollars paid through APMs, percent of dollars paid through facility capitation, if we want to dig into understanding how facilities and hospitals are capitated, or how many facilities and hospitals are capitated. We could look at changes in spending to support infrastructure and practice transformation. So these are the variety of things that we could report alongside our APM adoption goals. So with all of that, thank you for giving us time to walk through that. Wanted to open up for questions and feedback on the standards and goals, and the timeline, anything related to what was just shared. And Mohit, looks like you had your hand raised first.
To the draw. Now, first of all, thank you for all the work here, and we appreciate everything that's going on, albeit pretty quickly. We appreciate the engagement of the agency and the consultants and the staff and everybody. I just wanted to make some top line points. I think there is a level of recognition here about the ramp up of some of these APM things, and we appreciate that very much. However, I will point out, just for knowledge base and a fact base, that even the revised goals are more aggressive than HCP land on a national level. So that's important to understand, specifically for commercial PPO and for Medicaid. So we just need to recognize that others are not moving this fast, and systems, whether it's providers or plans, will have to significantly make investments to pursue these goals. The other thing I just want to raise, and we've raised this with other, many entities in the past, is a key driver to this whole effort is provider readiness. We have an inordinate amount of focus and pressure in what we are doing here on the payer side of the house. However, none of this occurs. I have our quality lead internally, reminds me constantly that, health plans aren't delivering the medical care, providers are. So this really does depend on a provider adoption metric that is not in here. So that's something to consider, that you can have it on the payer side, and this is part of our mission. We want to get more people into coordinated, high quality programming. but we need to understand from the provider side whether they are capable of moving as fast as this. And I don't know that we have that picture yet. The third thing that's important to recognize is that it appears that we're moving from this is guidance, this is working with all parts of the sector, to maybe moving more towards requiring this of the health plan community, which then gets me to the question of that's a change in tone and language. So we'd want to examine that, because then does that fall into enforcement action capability? Does it not? Are we going to be held to these 24, 26, 28, all the way to 2034? Are we going to be held to these goals with enforcement capability, or are these still outside of that scope? Because when we started this process, as you point out, Margareta, close to a year ago, we were not looking at these necessarily as enforceable, mandated, sanctionable event horizons. But so we appreciate some clarity on that, from moving to a guidance to a requirement. That's extremely important to get. And then the last piece is, you have in here different areas where you're saying, and payers could do this in contracting. And I'd like there to be a recognition at the outset of this conversation. What if the provider says no? Do we drop them from our network? What does that do to access? What does that do to network adequacy? What does that do for us in terms of having to ensure that we have viable access points and networks at the DMHC or other agencies, including DHCS? So the questions here really, first of all, as I said, I appreciate the forward movement on understanding how the market actually works in healthcare, but I'm also now concerned with this change in tone to the requirement side of things. And equally importantly, if we're supposed to do this in contracting, are there safe harbors that will be created if we fail to meet network adequacy, if providers choose not to do it? So that's initial just outset thoughts after looking at all the great work that's been done here. The one last piece I'll make, and I'll stop, is when you go back to the principles area, want to make sure that we at least understand, when we're talking about PCP coverage, et cetera, that there's some recognition that people get PCP coverage not solely in medical home, fully coordinated team-based care today. Not to say that that is not the goal, but people are getting coverage at OBGYNs. People are getting coverage at retail clinics. People are, those areas are billing PCP coverage codes. So again, as we look at the principles and we're trying to capture PCP, trying to capture APM, trying to capture team-based care, we need to also understand that there's a gradation across both products and gradation across providers that needs to be taken into account here. So thank you.
Thank you, Mohit. And I'll just, for one piece of clarification, in terms of the enforcement piece, the intention or what we are thinking of is only in terms of a performance improvement plan. So that is the only kind of potential enforcement mechanism that OHCA has in terms of kind of moving these goals forward. So it's not to say that OHCA has broader enforcement authority related to these goals, but that they would be tied to performance improvement plans that are implemented when a healthcare entity is not meeting the spending growth target.
And just as a follow-up to that, though, again, that is a change from where we started the process, right? So the enforcement piece of it, we were more looking at this as guidance. So we'd love to learn more about how that would work, because again,
Sure.
there's two sides to the coin. The performance improvement can be on the health plan, but if the provider community isn't at the table for that performance improvement, then it's kind of one-sided.
Sure, we can, there's a lot of work going on across OHCA to develop the enforcement process for the spending growth target. So there's definitely more work to be done and more work to be shared with you all in terms of the proposals there. So I think next I see Joe. Do you want to jump in?
Yeah, thank you, Joe Castiglione, Blue Shield of California. So there are definitely, I think, a few threads from Moit's comments that I'd be interested in pulling on. But first, I think we are generally supportive of the benchmarks that you said. It's really the commercial PPO, which is perhaps unsurprising to you that we actually do have concerns about. It's hard to know just where we land on the issue, particularly in light of a lack of clarity around where ASO will be counted, and in particular, if ASOIs will be included in the denominator, which it looked like I think I saw on one slide that perhaps they might be reported separately, but I just want to continue sort of the drumbeat of calling that out. We do know that there are limitations to being able to move those lives over to alternative payment models. I would encourage those folks on the call who've not seen the most recent issue brief that Crystal and her team over at the California Quality Collaborative released on this issue. I think it talks a lot about what we know the barriers to be. So I, again, just want to highlight that. I would also just in this theme, I guess, probe a little bit about whether you have considered a separate benchmark for Medicare Advantage PPO versus Medicare Advantage HMO, because those same issues do exist on the PPO side for Medicare Advantage. One of my colleagues just pinged me actually to raise that, so I wanted to make sure I mentioned it. And I think the final piece here, I'll try to keep it brief, is just plus one for Mohit on the piece on provider adoption, and in particular, what role the office or perhaps other stakeholders can play in facilitating collaboration to help providers be more ready to adopt some of these models. In particular, thinking about that PPO benchmark, and that a number of our in the PPO environment, right? Our members, that line of business is designed so that our members can go see providers that are anywhere in our network, right? They don't necessarily have to have a PCP. So that means that we need to have a conversation about what role specialists will play and how we put more of our specialists into alternative payment models. And there are a number of issues with that. I mean, some specialists, it just will never make sense to put them in an alternative payment model. Others just have member volume issues that are well known and are very difficult to get around. So I do think that is sort of another piece here that is outstanding, that I think it would be helpful to the plans in terms of how we achieve these benchmarks. So I will stop there.
Thank you, Joe. And I think we are want to support the provider community in terms of adopting alternative payment models. So very much intend to kind of keep that as part of our work. And as we move forward, look to kind of collaborate and work across the industry to promote additional providers being ready to and able to adopt and participate in alternative payment models. I know there's a lot of work going on across the state as well that we can support and emphasize. In terms of the self-funded piece, the piece you mentioned was some of the feedback we received about clarifying where self-funded lies within our alternative payment model goals. And I'll just say that that's kind of a bigger question that OHCA is wrestling with across the entire team in terms of how it relates to alternative payment models, how it relates to the spending growth targets. So we're continuing to work through those questions as an office. And Beth, go ahead.
Wow, what a rich conversation. So a number of things. I would think about the inclusion of the alternative payment model and perhaps probably primary care in a performance improvement plan. I would start off on the other foot, which is the research we're seeing, and part of the thinking behind OHCA is that it is more possible to meet the spending growth target if we are at the same time moving towards the adoption of alternative payment models and the emphasis on primary care. And I think that's actually a shared understanding. So rather than seeing it as enforcement, I would see it in that the performance improvement plan intends to move those things together. And I guess that's the way I would hope we would all think about it. The other reason that OHCA has this role on alternative payment model adoptions, and it also applies on primary care, is to try and move everyone in all parts of the healthcare industry in California forward on these things. And I think we all agree on what forward is. So it is entirely reasonable for the plans whom we expect to contract with providers to do these things to worry about provider willingness to contract. And also, I would agree that there are some specialists who just don't, it doesn't make sense for, never did, never will. And so I actually see, I was just re-reviewing this morning the hospital, the other work group on hospital spending and the background on that and how thoughtful OHCA is being in trying to distinguish, hospital spending, specialist spending, primary care spending. So I would just say this is part of that larger body of work. And so that is, I think, the way we're thinking about it. One of the questions I had, and this goes very much to the PPO conversation, especially on the commercial side, is, Covered California tried to encourage that consumers in PPOs have primary care providers, require. There were certainly some bumps in learning in the initial implementation, but I wonder if looking back on that work can help to inform some of what we're doing here and to try and move us forward in those conversations. Because I think we do, if we as a state are going to meet the spending targets, everything we see says we need to do the alternative payment model and the primary care changes that we're talking about today. So I'll stop there and we can talk more.
Thank you, Beth. Yeah, I think it is, as a piece we could follow up on it is kind of following up with payers and Cover California, and I think also CalPERS in terms of how the PPO, you assigning or selecting a PPO primary care provider in a PPO. So we can definitely do that. And
I would actually want to subdivide the self-funded market into those that are subject to federal law and those that are subject to state law. In the same way that the self-funded plans that are subject to state law contribute to the HPD, there is, just because they are subject to state law, there is more opportunity there for the state to take action. Thank you.
Sure. Mm-hmm. Bill, go ahead. We can't hear you, Bill. I wonder, are you called in on a phone? Do we need to unmute your phone line? Okay. Let me see if I can do that. See.
It does look like his microphone is able to be unmuted, but let me see.
Can you can you hear us now? Or Bill, can we hear you, I guess? Okay.
Let me try again.
Yeah, it looks like
Okay.
Oh,
Hang on, let me disconnect from the phone.
We can hear you.
All right. Sorry, I didn't have a choice when I logged in. I had to call in by phone. Okay, so I do want to share some of Mohit's concerns as well, and I'm intrigued by what Beth has raised in terms of this not being enforcement. My focus has always been on how we get APM into the self-funded market. And I know we're lagging in terms of data collection through the HPD on self-funded spending. But I did want to remind the group today that we obtained legislation back in 2020, AB 1124, which was a bill by Assemblymember Mainshine for a direct contracting pilot that would test the use of global capitation with self-funded payers. And we're doing it with a voluntary employment benefits association down in San Diego County. So, there is potential there for us to get some data very quickly on how that works. It is subject to regulatory oversight by the Department of Managed Healthcare, even though it's in a self-funded market. And we can provide some information on that down the road if you like. That's all.
So, Bill, this is Beth. I just want to say, look, that I spent an enormous amount of time with that VIBA on that proposal. The level of state oversight there, so the self-funded plans that are subject to state oversight largely involve public employees where there is a strong labor presence. And that's very different than the broader self-insured market that's subject to federal regulation.
Yeah.
And so that's part of the reason why I wanted to distinguish between the two, is that opportunity for state oversight, it creates a different dynamic than in the larger self-funded market. And in case anybody is confused about this, health access continues to regard it as a basic consumer protection that provider organizations taking risks should be subject to state regulation. And I don't think we're going to change our mind on that anytime soon.
Yeah, I don't disagree with you.
Just so that,
Yeah.
But I think there's some confusion out there in the world. And so I want to, not about health access's view, but.
Yeah, but I do want to just remind everybody that, the Knox-Keene Act is, I don't want to say this harshly, it's a barrier to moving into class 4 under the LAN in the self-funded market. And, if you want to get to these high rates of usage of alternative payment models, that is going to have to be addressed at some point in the future.
Bill, it's not a barrier, it's consumer protection. We just have a completely different perspective on that.
No, I'm not sure I disagree with you, Beth. I mean, I agree with you that if providers are going to take risks, they should be overseen by DMHC. I don't disagree with you. I think we found a way to do that in the pilot, but we'll see. We'll see how it turns out.
I appreciate all the discussion about the self-funded piece, and I think it's a question and an issue that us as an office, OHCA kind of needs to work through on a broader scale, like in addition to how it impacts alternative payment model goals, but also the spending growth target. So I think maybe we can do some kind of like follow-up offline conversations and like dig into the details and the concerns, and appreciate all of you who have shared, context and information in writing. It's really helpful. And we've also, we've dug into the issue brief that the CQC team developed and found that helpful to inform our thinking. So I think appreciate all of the kind of nuance and challenges that the self-funded question presents. But I think based on our time today, would ask that we kind of move on to primary care. And again, if you all have questions you want to, or like issues you want to flag in the chat about the self-funded question, we can follow up on those and dig into those offline. Because I do want us to have enough time to share all of the additional nuance that we are working through with the primary care measurement recommendation and also our investment benchmark recommendation. So if you all have additional feedback or questions related to the APM standards and goals, please feel free to send that to us via email or put kind of initial thinking in the chat. So for this next section, I'll initially turn it over to Debbie Lindis, our Healthcare Delivery System Group Manager, to walk through our proposed approach to primary care spend measurement. And then in the next section, we'll share also our investment benchmark proposal. So go ahead.
Great, thanks. You can go to the next slide, Margareta. So, as Margaret already mentioned, today we're going to focus on the final outstanding decisions leading up to our primary care spending measurement approach and benchmark recommendations that we're going to be presenting to the board next week. And these are whether to exclude or include OBGYNs in our definition of primary care, aligning our OHCA code set to the DHCS targeted rate increases codes, our approach to allocating primary care spending via capitation, and our primary care investment benchmark. And so we'll be diving into those in the remaining slides. And to start, we'll talk about OBGYN. So as a reminder, OHCA's recommended definition of primary care includes some OBGYN services when provided by a primary care provider at a primary care place of service, but we're recommending that all services provided by an OBGYN provider are excluded from measurements of primary care spending. And our rationale for this recommendation is that it aligns with the workgroup's focus on investing in providers who provide continuous whole person care for all body systems, which OBGYNs often do not meet this definition. We note that excluding OBGYNs in our payment definition doesn't in any way change consumers' rights under the Knox-Keene Act to select an OBGYN as their primary care provider. And according to unaudited health plan self-reported provider data that's submitted to DMHC, 9% of all primary care physicians reported by health plans were identified as having a specialist type of OBGYN, and 72% of all OBGYNs reported by health plans were identified as serving as PCPs. So we'd really like to better understand if these OBGYNs who are identified as PCPs are providing services that align with our vision and definition of primary care. And so we propose to explore this in the future through additional analyses using the Healthcare Payments Database, or HPD. So based on future available data, we may revisit the question of whether OBGYNs should be included. And finally, we want to note that the majority of stakeholder feedback received to date supports this approach as being most aligned with our future vision for primary care. Next slide. So looking at our services code set and kind of tracking our process in developing this, we initially started with applying your guidance to a crosswalk of 15 state and national primary care definitions. The crosswalk contains 13 code sets from state agencies and nonprofits, including from the Integrated Healthcare Association, and 2 code sets from national efforts. And then in light of publication of service codes that DHCS has deemed eligible for targeted rate increases, OHCA compared our draft primary care services code set with the TRI codes. And then we revised our code set to include those codes that aligned with our primary care vision. And I'll discuss that a little bit in the next slide. But finally, we found in comparing our revised draft code set to the crosswalk of primary care definitions, we found that our final OHCA code set is larger than any other state, regional, or national definition. And it includes some codes that no other definitions include. And we'll be sharing the current draft code set with the work group for your feedback. Next slide. So this is just some highlights of the changes that we made based on our review of the DHCS targeted rate increase code set. So there were 582 codes that were included in the DHCS set, but excluded from the initial OHCA draft definition. And of those, we recommend adding 252. Most of those are not included in any other primary care definitions, but they do align with OHCA's interest in a broad definition that promotes comprehensive primary care. And also some of these codes are more likely to be used by Medicaid, which is important for us to include, whereas many other states' definitions focus on commercial populations. We do recommend continuing to exclude 330 of the DHCS code, typically for one of the following reasons. One is primary care providers would be unlikely to have the specialized knowledge, training, or equipment to perform some complex procedures that are included in the DHCS code set, or the care would occur in a setting such as an inpatient setting, which is not included in our primary care definition, or by a provider that's not included in our primary care definition, such as a licensed clinical social worker. So we do anticipate that most of these added codes will be used relatively infrequently and have low associated spend and low impact on our overall measurement. Next slide. So these next 3 slides are going to recap at a high level our recommendations for measuring primary care investment paid via non-claims using the expanded framework categories. So the first 2 recommendations are that for category 1, population health and practice infrastructure payments, and category 2, performance payments, the approach is the same. All the non-claims payments in those categories are allocated to primary care when they're paid in support of primary care programs. Some examples of such programs would include care management, care coordination, and population health. Performance incentives in recognition of quality or outcomes of patients who are attributed to primary care providers would also be included here. Payers would be required to limit the portion of practice transformation and IT infrastructure payments that count as primary care to 1% of total medical expense, which based on 2021 California commercial market data amounts to more than $5 per member per month. And this approach is consistent with similar policies in other states that aim to recognize that these types of payments tend to have a broad impact that's beyond just primary care. Next slide. For category 3, shared savings payments, the portion of the risk settlement payment allocated to primary care would be limited to the same proportion that claims-based professional spend represents as a percent of the total of claims professional plus hospital spending. Next slide. For category 4, capitation payments, the approach is going to depend on the type of capitation payment. So for primary care capitation, 100% of that is allocated to primary care. For other capitation payments, data submitters would calculate a fee-for-service equivalent based on a fee schedule for primary care services multiplied by the number of primary care encounters. And the next couple of slides will review that methodology in more detail. Next slide, please. So here's our original proposed approach. Just to recap it briefly, in this methodology, the capitation payments allocated to primary care are based on encounters times fee-for-service equivalents, using fee schedules that specify fees for each primary care service broken down by payer type, geographic region, and year. So we've seen this graph several times, and we can go to the next slide. An alternative approach that was proposed by Blue Shield is shown here. And based on stakeholder feedback that I'll review in just a moment, OHCA is now recommending this approach to allocating capitation payments to primary care. So this approach does the following. In the top box, you can see that all payments for category 4A or primary care capitation are included, plus in the middle box, or the middle section, we calculate a ratio of the sum of primary care encounters multiplied by their fee-for-service equivalent fees to the sum of all professional encounters multiplied by their fee-for-service service equivalent fees. So essentially, we're creating the percent of all encounter payments that went to primary care services. And that ratio is then multiplied by the professional capitation amount to get a dollar amount allocated to primary care. And that's added up to the primary care capitation to get the total primary care capitation amount. So this example is envisioning a professional capitation. If we had a global capitation, the professional encounters and capitation in that formula would be replaced with all encounters and the global capitation rate. And based on a review by the OHCA, this methodology would produce comparable results to the methodology they used in the California commercial primary care spending study. Next slide. So here we're comparing our initial OHCA approach with the Blue Shield recommendation. So first of all, the initial OHCA approach is simpler than the Blue Shield recommendation. The OHCA approach only requires primary care encounters and fee-for-service equivalents, while the Blue Shield approach requires encounters and fee-for-service equivalents for all care that's included in the capitation. So in both of these approaches, low quality encounter data poses a challenge. A second point is that the initial OHCA approach does not adjust for missing encounter data. So spend that's associated with missing encounters would be completely missed in that calculation. Under the Blue Shield approach, the challenge is a bit different. In that setting with the ratio, if encounter completeness varies by the care setting, so primary care versus other professional encounters, this could either undercount or overcount the percent of primary care spend. A benefit of the Blue Shield approach is that it accounts for payments that are included in capitation but not captured by encounters, such as care management, for example. And then finally, the OHCA approach will likely result in a lower primary care spend than the Blue Shield recommendation. Using this revised methodology, OHCA would monitor payer submissions for reasonableness and will encourage all payers and providers to continue to improve the quality and completeness of encounter data that they submit. Next slide. So before we open up for discussion, we just want to share some of the recent stakeholder feedback on these approaches to calculating non-claims primary care spending for capitation payments. So stakeholders here and in the advisory committee have highlighted the distinction between measuring primary care spending by plans versus by provider organizations. Primary care spending by provider organizations may not be captured by counting encounters and applying fee-for-service equivalents. So some examples of this type of spending would be population health management capabilities, payments to non-billable providers, pay-for-performance programs that are managed within the physician organization rather than by the plan. So measuring how provider organizations distribute capitation payments to downstream primary care providers would require additional and more flexible data collection. In order to improve the accuracy of our estimates of non-claim spending on primary care, stakeholders have suggested that OHCA should start investigating such provider-level data collection as part of its longer-term planning process. Some stakeholders have had concerns about whether encounter data would be of sufficient quality and completeness to support the analysis of primary care spend in capitation, regardless of the calculation approach. And at least one workgroup member has found that OHCA's original recommendation was a reasonable approach. Finally, payers who have provided feedback to OHCA on this question have mentioned that the Blue Shield approach better reflects payments intended for primary care that are not tied to encounters. So next slide. And so now we'll open it up for discussion and would like to hear your feedback on the recommended approach for determining primary care spending paid via capitation.
Thank you, Debbie. Yeah, I appreciate this is kind of a complex and technical issue that you all are working through with us, and appreciate all of the feedback and recommendations we've received so far to get us here. So Mohit, go ahead.
So a couple of, again, not definitional, but grounds, level setting points, if you will. I think first of all, again, thank you for the ongoing work here. It's very important to get this right as well. We continue to believe on a fundamental level that the service provided should be counted. And we've had this many times over with this group, not necessarily the setting of that service. I understand inpatient being a different deal altogether, but outside of that, we continue to be concerned that we are fundamentally going to undercount primary care spend in the state of California because of how people receive that care. It goes back to the OB thing, goes back to the minute clinic thing that we've said many, many times before. In order to have a clear pathway, you need to start from a clear starting point. And by muddying the water, by counting selectively, we're not going to do that. So that's one thing. Our recommendation on the entire CAP versus primary care or in totality has been that if OHCA does end up with this more limited definition of primary care, that there be a more inclusive side definition that also is very specifically calculated, and that there be a comparison of the two over time to see A, which is more accurate, and B, very importantly, to show the crossover that occurs over time. Are more people coming into this medical home fully coordinated capitation and PCP arrangement versus those that might be getting primary care codes paid in other settings? So again, we'll just emphasize that we want to have apples to apples. We want to make sure that the broader definitions are being considered at all times. And you just pretty much provided the reason for that, given the TRI funding. If the TRI funding is looking at 582 codes and OHCA selectively uses 252, you're essentially having a definitional problem between and amongst agencies. And remember, we are regulated by multiple agencies, and we have to do what the agency that runs our regulation requires us to do. So essentially, you're setting up a situation where some of the spending that DHCS is counting towards primary care in a massive targeted rate increase, which we can get into the impact on the overall cost benchmark of that increase. But if you're not counting sufficiently what one agency that provides coverage for 14 million Californians is doing, then you're not getting to a complete picture, in our view, of a standardized view of primary care that everyone can run with. Now, I'm not saying, we've gone through this definition issue for a while, but all I'm asking for is some consistency in reporting. If there's a report created for primary care, the way OHCA envisions the future of primary care, there should also be complete transparency of what's being left out of that report. That's one. And then the second is not aligning across and amongst agencies will create confusion in the medical market.
Thanks, Mohit. So I think just to emphasize that any reporting that OHCA does on the primary care investment or spending towards the primary care investment benchmark, primary care spending will be complemented with our definition and what's included in the definition, what's excluded in the definition, to be very clear about what we are counting. I'd also note that we recognize we are leaving some sites of care like retail clinics out of our recommended definition. And we're intend and kind of thinking about how we could use the healthcare payments database to better understand the use of those sites of care for primary care services. So that is something that we're continuing to think about and will explore in the future. I'll just note that in evaluating the DHCS targeted rate increase, we did speak with the DHCS team about how that was developed, the process, and kind of we recognize that there are differences in our approaches, and our approach of incorporating those codes is really intended to align back with the vision and kind of the definition that the team has developed, this work group and the team has developed over time. So it's not that, I think it's a difference in terms of, approaches and vision, not necessarily that there are like major differences between or kind of conflicts between the two departments.
Yeah,
It's
no,
just
I,
kind
I
of
wasn't
different
suggesting,
approaches
yeah,
to the work.
I wasn't suggesting conflict. I just wanted to make sure that we understand, that's why I think having that definition made public is one thing, but having a subsequent reporting of what the full or the broader definition might include would also be very helpful, because I would hate for people to think that we're not spending on primary care when we are. And that becomes a issue in the public. You need to keep the public trust. And in order to do that, having a narrower definition that leaves out, hey, I know I got my shot from this physician. It might have been in a minute clinic and not in a PCP office. I got my primary care, but it's not counted. So having both reports, in my view, would allow the public, the purpose of this, the consumer, to understand what is truly happening, as opposed to what I agree with is a limited definition of where we want to be down the road. So thank you for that.
Sure, Beth, go ahead.
Yeah, we continue to support the approach of moving towards the vision of coordinated primary care. I guess if we were going to do some version, and I'll leave it to staff to do the work to figure out all the details of the kind of supplemental reporting that Mohit suggests, what it might show is that some parts of our market are lagging behind where we hope to go in terms of coordinated primary care. And so I think that's, that may be important information to OHCA to have as we move forward. If, for example, we found a plan that was unduly reliant on uncoordinated retail clinics, that would raise concerns for us. And conversely, if we had a plan that had coordinated primary care that was not named Kaiser, and that had ready access to primary care for enrollees, which doesn't happen in commercial coverage in Sacramento, that remote rural area outside of Kaiser. That's an area of concern for us. And that's part of the reason why we think it's so important that we're moving this work forward. So I don't hear, Mohit, I hear you agreeing with the goals, but having questions about how we're getting there. I would also say that the targeted rate increases that accompany the managed care organization tax are aimed at fixing the recognized deficiencies in our current Medi-Cal managed care system. And we support doing that, but that's a very different task than the moving forward that OHCA is engaged in. What OHCA is doing is looking ahead the next decade. What DHCS is trying to do is to make up for 30 years of insufficient rate increases for primary care providers, which goes hand in hand with we don't fund primary care enough in the state. So I guess we just have a different perspective on that. So thanks.
Thank you, Beth. Kevin, go ahead.
I'll start just by saying it's so often the case I find myself entirely agreeing with Beth. So well said. It's so hard with this non-claims payment approach to try to capture legitimate spending and non-claims for primary care. And, there's no perfect way to do this. I will say I'm a little worried that we start to double count stuff when I'm looking back on, slides 27, 28, and then getting to the, how to think about the capitation formula. There's stuff like, if you go to slide 27, for example, there's, you have care management stuff and pop health stuff, that's paid. I guess that's by the health plan, and then you then get to another level, and you're trying to capture some of that paid by the medical group maybe. And I just you start to count a lot of stuff that's not directly the frontline primary care. And this is where Adam and I, had a long conversation. And I think it really paid off in item 3. If you go to the next slide, where it was like, okay, let's look at, I like this approach here of looking at all the, payments and how they go to specialty versus primary care. And that kind of guided how you allocate these types of shared savings. And yes, I guess I was thinking that would be the approach for if we go back up the slide before. Would we want to use that for 1 and 2? If you go like 1 and 2, if you go back up to the slide before, let's just take social care integration. Like a lot of hospitals are jumping into that because there's now joint commission stuff, where you'll get special equity, gold star if you're doing that on all the patients admitted to the hospital. And I just, none of that is going to be done in primary care. So I worry about a lot of this stuff is not really primary care. So I guess I wouldn't out of hand say all those categories, every last dollar gets counted, that there should be something like Adam and I had brainstormed about some share of that maybe. So I guess I'm not sure why we're not applying the formula from item 3 to some of these kind of items. The Blue Shield approach to revising the one, I get it. The dummy claims don't capture everything that goes on in a capitated environment, but there's risk there. I'd probably go with the original approach we're coming up with. If there's a consensus to go with the Blue Shield approach, I'm not sure I'd multiply it by 100% of the total cap. So if you go to that Blue Shield one, yeah, like that final times professional capitation, I might do some, 90% of the total, professional capitation, because a bunch of that is still going to be, some of that total cap is being used by a medical group or something for some administrative stuff, some other things for reviewing, again, hospital admissions and for their infrastructure, do a lot of stuff that, again, I don't think would really fall under primary care. So I would not give 100% of professional capitation, but give some prorated basis like 90%, 85%, something like that. Just a few thoughts. But maybe that's a question, Margarita and Deb. What did we think about for item 1 and 2? Maybe the performance payments, if they're really primary care. But even there, some of those like performance payments may be hospital-based one. They may be surgical infections or catheter-associated infections that are nothing to do with primary care. I guess I would think about all those ones being, as a, kind of the share of that based on this specialty versus primary care split of the capitation. Did you guys consider that or not?
Yeah, so and maybe this is kind of a little challenging to walk through, but essentially, our primary care claims-based definition is intended to work in tandem with the non-claims-based definition. So for like pay for performance programs, it's the pay for performance incentives that are for primary care providers, not for hospital-based pay for performance programs. And same with like the care coordination fees, that it's intended to be narrowed to those that are paid to primary care providers or primary care practices, not the broader set.
Okay, I'm sorry, I missed. And that's really helpful to clarify. You may want to, maybe, I don't know if anybody else was confused about that, but you're really able then to distinguish those payments, let's just say pay for performance, that don't just go to a large, giant integrated health system, but really the pieces that are going, well, even there, I don't know, like for a large integrated system, often the pay for performance just goes to the whole system. So how to know how much goes to primary care is tricky.
Yeah, it is tricky. And I think in addition to kind of our high level definitions here in the data submission guide where we collect all of this data, we're going to have very detailed technical definitions to try to kind of clarify what counts and what doesn't. Mary Jo, do you want to speak to that? I think you're on
You're
mute.
Hear me okay, Margareta?
Yes, thanks.
So are you hearing me twice? Okay. So I want to speak to both pieces, actually. So with regard to Dr. Grumbach's comments, yes, do you want to make clear that it's only that portion that's going to be going to primary care providers? You might think of it as, for the patients that are attributed to those providers, for example, that PMPM is generally based on something. So that's one way to sort of ground it. I was also going to respond to Adam's comment. I'd like a little bit of clarification, though, with regard to Adam's comment, because I'm trying to distinguish, and I think it's important to distinguish as to whether or not he's referring to the numerator or the denominator. So the numerator is only going to include our primary care code set. The denominator could potentially include any code that's included in the capitation, because it's really designed to align with the capitation. So Adam, if you could clarify that just a bit, that'd be helpful.
Thank you. So because the fee schedules and the RVUs tend to be skewed much higher for procedures than they are for professional cognitive services, if you go all in and you're only looking at encounters, and you're saying encounters means any billable code, then in essence you're not including the non-billable services that we're trying to get into or trying to get to the bottom of, but you are including higher cost procedural codes, which will skew the balance toward or away from primary care. And so because the goal of this exercise is to be able to attribute this additional funding or this non-claims funding towards all of those services that are typically not captured in encounters. And so this calculation is skewing it in the other direction and doesn't necessarily recognize that value. I think I prefer this definition to the other definition. It gets a little bit closer, but that is my concern. And as long as I'm talking, I'll just mention back, and Kevin and I have had some great conversations. We come from slightly different worlds, and from an environment where we provide comprehensive, continuous patient-centric care, the group, not the hospital, the group is providing a lot of those social service, and community-based, all of that work, all that coordination, all of the needs for the population that this group is at risk for. That's coming out of the group. It's not coming out of the hospital. Yes, at certain times, hospitals might be doing some of this work, but it's throwing a bullet versus shooting one. It's completely different. That's just my perspective.
So, Adam, I know that we only have a limited amount of time today, and I think that you've raised an important point. I'm wondering if we could follow up with you and explore it offline.
Absolutely. Happy to.
Great, thank you. And Carrie, go ahead.
Yeah, hi. I think I just wanted to, align my comments with what Adam was just saying. I think I appreciate on slide 27 seeing the non-claims primary care spend measurement approach that's inclusive of a lot of the population health and practice infrastructure changes that we're really hoping to see come out of this focus on advanced primary care payment models. So I'm happy to see that here and feel like this is a positive. I think just for my understanding, because I know there's concerns about sort of how the calculations so just so I understand all of these different, the claims and the non-claims, they're all together part of the numerator. Is that correct? Or yeah, okay. And then the other question I have, and maybe to just, to kind of understand better, what the concerns are that folks have, are the claims versus non-claims expenses, weighted similarly, or are there, different weights? No, okay.
Yes,
And
not applying any weights. We're trying to kind of use these calculations to make, for non-claims especially, use these calculations to make our kind of best estimate of what is the portion, for example, of a capitation payment that it supports primary care.
great. Yeah, and just, I think, we would like to get to a point where, we can actually look beyond just service codes to understand, who who's providing some of these services, what the provider, types are, et cetera. And I realize that may not be, in the purview here, but the idea of a primary care team, and others really helping to provide that care is, I think, also, important information that we would love to see this, see all of us have a better handle on. Thanks.
Thank you, Carrie. I think that's potentially something we could try to explore using the healthcare payments database. And also, just want to also emphasize that our on the claims-based definition of providers, we are kind of more inclusive, or intended to be more inclusive, to include many primary care team members, not just primary care physicians or clinicians. Kind of to get to your exact point of that team-based approach to primary care.
Thanks.
So I was concerned this might happen, but Catherine, go ahead. Yeah, we only have a few minutes left, and we haven't gotten to our proposed benchmark. Go ahead, Catherine. Oh, sorry, Catherine, we can't hear you. Or I can't hear you.
Greta, do you want to go to the benchmark and then we can circle back to Catherine?
Sure. So I think I will probably just skip all the way to our proposal. Some of these slides you all have seen before. And we also, in these slides, we shared some experience in other states. So for, based on all of kind of the feedback that we've heard in the work group, and also the kind of analysis and work we've done internally to try to understand what's feasible in terms of a primary care investment benchmark, especially as we discussed for adult versus pediatric benchmarks. We just found it would be quite challenging to separate primary care spending by adult versus pediatric populations, especially in a non-claims space. So kind of you add another layer of estimation on the non-claims primary care spend when you try to separate them by adult versus pediatric. So that is why one of the reasons that we are recommending a statewide absolute benchmark of 15% of total medical expense allocated to primary care for all payers, or across all payers and populations, by 2034, along with a relative improvement benchmark that promotes increases in primary care spending by 0.5 to 1% per year, depending on the payer's current level of investment, getting up to that 15% benchmark. We really want to emphasize that we monitor progress towards the benchmark each year and report on progress. As I mentioned, the absolute benchmark single absolute benchmark reduces administrative complexity and reporting. And we think, to try to better understand the difference between adult and pediatric primary care spend, that we could try to use the healthcare payments database to complement our reporting on primary care spending. We also think that, kind of in reporting, it also may be helpful for us to report the population distribution of a payer. So, what's their pediatric population percent, what's their adult population percent, as context for reaching this 15% benchmark, and the relative improvement changes they're making year over year. So I will stop there and see if anyone has questions or feedback in our last minute or two, and start with Catherine.
Sure. Can you hear me now, Margareta?
Yes, thank you.
Okay, thank you. Sorry about that. So first, support the benchmarks as written and really appreciate the documentation you've provided. I know there was a question earlier about the timeline for benchmarks. So two thoughts there. I think a 7-year versus a 10-year makes a lot of sense and would align it with APM. I think it's a powerful signal not only that these are complementary, but intertwined. So would encourage you, whatever year you peg to APM, do the same thing for the target. It's just confusing to have them different. And I think a missed opportunity on that signaling. So one quick thought there. And then my earlier question or comment, really appreciated. This is in terms of the equations, the math, the algorithms, it's very technical. Agree there's no right way to do it. But it really strikes me from a conceptual level that this whole endeavor is trying to do two different things. One is trying to drive investment to primary care. So primary care providers and teams have the financial resources they need to deliver and execute on the vision of primary care we've set, right? Whole person care, all of that. We're also trying to signal and hold plans accountable for reallocating and redistributing resources away from other types of services and to primary care. And those are different. Like, they're both equally important goals, but they are different. So as you're going through that next set of sort of what are the trade-offs between how we think about capitation and how we think about the right quote unquote math equation, would ask you to hold those up. Is there one that does both of them versus just one of them? Do they require different maths? But how do we think about that? Because getting more dollars in the hands of teams and providers to deliver excellent care to patients may be a different type of quantification than how plans think about where they're placing their budget next year, 5 years, 10 years down the horizon. Thank you.
Thank you, Catherine. That's a really important consideration, and we can definitely kind of take that back and think about it more in terms of the capitation allocation formulas. And I saw another hand raise. I think Amy, is that you?
Yeah. Hi, Margaret. I know we're over time. One question and then one comment. The 15%, do we have like an average PMPM equivalent for that?
We can take that back. We are able, I think we would be able to, using the IHA data, be able to estimate a PMPM for baseline spending. So we can take this back. Sure.
Okay. Because that would be helpful, right? Just to kind of translate that. And then I just wanted to add for the notes that if this, if we can really accomplish this, I agree with Catherine's comments. It's extremely powerful what this can do. And I just ask that we also relay this back to, upstream in the pipeline with our medical school training and our clinician training, so that those are aware of this primary care investment, right, in our state, and those students can really have the informed data points, right, to make their decision to go into primary care. Because I do think it's important to loop back upstream as we look at the pipeline and look at the future of primary care.
Sure, that's a really good emphasis that we can follow up with our partners across OHCA in our Office of Workforce Development, who focus on that exact thing. So good flag. And Mary Jo, did you want to mention something?
I just wanted to take a minute to respond to Adam's comment in the chat. So I want to note that the claims-based definition that OHCA is proposing is actually broader now than what was used by IHA. So it's not, which is the data that is referred to in the deck. one way that OHCA's definition is a little bit more narrow or could result in a slightly lower is it's doing more, it's proposing to do more to sort of key in on those primary care providers through that extra step of looking at those who are designated as primary care with DMHC. But I also want to note that the non-claim spending that is going to be included is broader than what was included by IHA. So I think these things are going to all balance out, and I wouldn't be concerned that the OHCA definition is much narrower than what the IHA data has suggested so far.
Thanks for that flag, Mary Jo. And so I know we were quite rushed these last few minutes, and we're over time. So if folks have any suggestions or initial kind of thoughts or reactions to this benchmark proposal of a relative improvement benchmark and an absolute benchmark of 15% by 2034, would welcome you all to send us feedback via email. And then also we will be coming back to the work group in May to discuss further and bring back any feedback we heard from the board when we present next week to the board. So there's still plenty of time for us to work through the primary care investment benchmark over the next several months. So thank you for all of your feedbacks today and all the great discussion. And we will see you next month, and feel free to reach out in the meantime. Thank you all.